patient to weigh themselves every day, what are we going to do with the information? Well, first of all, we know that 2.2 pounds equals 1 whole liter of fluid. Oh my God. So the patient needs to weigh themselves every single day. And then get this, call me. I call it a call if. Call if 3 pounds in a day or 5 pounds in a week. Got that? Just in case you think I'm playing, my family knows the same rules. So my mama, she calls me with this craziness, these more than 3 pounds in a day. In fact, I think it was 5 or 6 pounds in one whole day. She weighs herself every day like I taught her to. She has a pacemaker. She has a little bit of congestive heart failure, really mild due to the AFib and hypertension. She has kidney, stage 3 kidney failure. And so I told her, I bet you better weigh yourself every day, mama. So she weighs herself. She calls me with this craziness. She has for her AFib a pacemaker. She's on digoxin, amiodarone. She's on a lot of crap. Synthroid, whatever. So she calls me to tell me that she's gained all this freaking weight. I'm like, call your cardiologist. This is not normal. She calls a cardiologist. He says, you know what, I want you to come on in. Let's check out what's going on. She gets into the cardiologist. Guess what? Her pacemaker stopped working. Hello. She would not have known that until it was 2 days too late, and she's setting up in somebody's hospital, nasty hospital, because you know all hospitals are nasty, they got germs. She's setting up in somebody's hospital with pulmonary edema, you know, that pink frothy sputum, not cool. So yeah, you gotta know this. You gotta know that this patient needs daily weights. If they're on a diuretic at all, they need daily weights, okay? Now, hopefully you're hearing me loud and clear because we're moving on. If you look at this page, you have all of your diuretics. It is the best page for diuretics because here we go. Number 1 on the left side is that hydrochlorothiazide, right, that Hctz like I told you, and put potassium wasting. On the right side of your handout is furosemide. It says Lasix. You need to put bumetanide or Bumex. You already saw that on the other page. Again, potassium wasting. If you go down the page, you will see it says something in the middle of the page called the loop of Henle. Highlight that. You'll need to know that in a little while. Go to the very bottom and look at the circle at the bottom. This is what I would call a select all that apply. You have a select all that apply in what in God's name are diuretics used for? And you had to know. Basically, organ failure. Any organ failure. So let's look at the little box. CHF is an organ failure. So congestive heart disease. CKD. Why am I having a brain block? Oh my God, this is terrible. Acute versus chronic, right? So chronic kidney disease. So kidney failure, heart failure. And here's the third C, cirrhosis. There you go, cirrhosis. Cirrhosis is liver failure. All of these failures are treated with a diuretic. And then, of course, the last one you see is high blood pressure or hypertension. That's kind of like important, okay? Now, in the bucket, OMG, that is yet another, here we go, select all that apply. So if you don't know your decreased blood pressure, decreased sodium, decreased potassium, and I need you to add one more at the top of the list, and that would be decreased blood sugar. Oh, I lied. Increased blood sugar. You can see it at the bottom. It says hyperglycemia. That's increased blood sugar. Here is what I want you to write because they forgot an electrolyte at the bottom under potassium. You see they go with the arrow up. They don't have an arrow, but they say hyperglycemia. So do me a favor, at the top above the blood pressure, I want you to write decreased calcium, because that is also decreased. I'm going to come up a little close so you can see how I did it. If you look at it, I've got that decreased calcium with all my electrolytes. I kind of put that hyperglycemia there, and then I go in the middle and put the high blood sugar just to remind me, nice short little high blood sugar. And then of course you see the rest of this, okay? Now, I promise you, you have to know the effects of diuretics. You must know that these are exactly what happens with diuretics, okay? That's why when a patient's electrolytes are too high, one of the actions is to stop the diuretics. One of the actions is to give the patient a diuretic. So stay with me. Come over here. If we are treating hyper or high electrolytes, and you can write that on this page or the one before it because you have so much more room. The one before it was this page. You might want to write it on that. If we are treating hyper or high electrolytes, the first thing we're going to do is start an IV and give a fluid bolus. If it applies, we'll give an antidote, magnesium. The antidote would be calcium gluconate. Diuretics are right there. And consider dialysis. That is true for anybody with really high electrolytes or hyper whatever it is. Again, IV fluid bolus, give the antidote if there is one, give diuretics if it applies, and consider dialysis. Those are huge. They're absolutely huge. It just is a nice little trick whenever electrolytes are high. Now, I want you to make sure that you put a couple of things, and you're going to have to put those things up there by hydrochlorothiazide first. So up here, where it says hydrochlorothiazide, I need you to put thiazide diuretics. Work on the distal tubule. Thiazide diuretics, they actually work on the distal tubule. Okay. Now, loop diuretics. Loop diuretics are called that because they work on the loop of Henle. These are all structures in the kidney, which you probably know. Okay, now before we turn, you have one more thing. Whenever we give diuretics, and God forbid the patient takes too many, they're going to have pale urine and a decreased specific gravity. They're going to pee a lot every 20 minutes for the first couple hours. So when they take this diuretic, they need to take it outside of 6 hours if there's some activity in there. Let me give you examples. If I am going to church on Sunday, and I am, except it's closed down because of coronavirus, but if I'm going to church on Sunday and they put me on hydrochlorothiazide or they gave me Lasix, I know that I cannot get up every 20 minutes at church to go pee. That's crazy. So as soon as I get out of church, I'm going to go ahead and take my diuretic. So within the 6 hours of an event, don't take a diuretic because you're going to be getting up all the time. I know exactly who's in my class that's on a diuretic because I get up every 20 minutes. I already know who that is, all right? So that's one thing, right? And then we said the urine will be pale and they will have decreased specific gravity while on the diuretic. Now, loop, you've got to know your loop diuretics. Loop diuretics are ototoxic. Watch this. Loop diuretics are ototoxic. What in the hell does that mean? That means that you can't hear good if you get this and it's kind of toxic to the ears. So if you turn the page, we're moving, you're gonna come on with me. If you turn the page and we look at an example of a loop diuretic called bumetanide, we are going to make sure that we focus on some of the problems with the loop diuretic. Now, so do me a favor. At the top of this handout, really big, I want you to write Ototoxicity. Ototoxicity, right? That's what I want you to write on the top of the page, because bumetanide, is ototoxic. I also want you to write up under the words, just like Lasix. Write that down. Now I want you to write a select all list, because you have plenty of room. Over in the side of the page, I want you to write, here we go, all the ototoxic drugs. And make sure you put select all that apply. And let's give you a bunch of them, because they're kind of popular. Here we go. Loop diuretics are ototoxic. Aspirin and NSAIDs are ototoxic. Aminoglycosides are ototoxic. You know what this is. This is your vancomycin, your gentamicin. You've got to kind of know vanco the most, so let's just put our vanco there. And then chemo. Specifically, the chemotherapy agent of cisplatin, which is popular. I think it treats like leukemia or some shit. Cisplatin. Okay, so the chemo drug of cisplatin is ototoxic. Here's your favorite, the other ototoxic drug, woohoo, Viagra. Now you know Viagra's not on the test, so what is? Sildenafil. I think it's sildenafil something. Check the spelling, because your girl can't spell. And I do teach you that the ding-a-ling drugs end with fill, F-I-L, because they fill up the ding-a-ling with blood so that the patient can feel good. Okay, feel, whatever. Anyway, you get it. Now, I love this page. I absolutely love this page, because another select all that apply for a lot of you. Here we go. Another select all that apply for a lot of you little sweethearts can very often be indication for the drug. So let's look at the handout. Like I said, I love the handout. If you look at what would be the indication to give a patient a loop diuretic such as bumetanide or bumetanide, then on the page are all the pictures of all the different reasons to give the drug. So stay with your girl. On the left-hand side, there's a pair of lungs. On that, you need to write two things. Pulmonary edema, and you need to make sure you write this. I swear you need to write this. For pulmonary edema, you need to write pink, frothy sputum. Look at that. I even made it pink. So pink, frothy sputum. Another lung condition that we use loop diuretics for is ARDS. So you need to put ARDS, acute respiratory distress syndrome, ARDS. If you go to the right-hand side, you'll see the heart. You'll see it says I'm having left-sided heart failure. Make sure you add right-sided heart failure too, because both heart failures need Lasix or Bumex. So CHF, right? Go down a little bit, you'll see the kidneys. AKI, CKD, write it. You got that? Okay, now check this out. If you go to the bottom of the actual page, there are all the different indications for what you're using it for, and the side effects and the daily weights and all the different things. I want you to focus on this bubble right here. On the top of the bubble, I need you to write, or maybe like right below it, I need you to write this. I already gave you indications. I need you to write action of loop diuretics. Okay? Action of loop diuretics. Now, here's what it says. I'm just going to read it and we're going to play a little bit. It says, bumetanide promotes diuresis by inhibiting sodium and chloride absorption in the ascending loop of Henle. Listen to me. If I say it inhibits, these drugs inhibits the absorption of sodium and chloride, which every time I say sodium, you better add water. So if I were to add anything, I would be bumetanide promotes diuresis by inhibiting sodium and water and chloride. So if I am on this medicine and I'm inhibiting, so I'm stopping the absorption of sodium and water, then that means I'm excreting it. Do we agree? Yes, we all do. Okay, so that's called diuresis. I'm peeing. Okay, now I could have said this a different way. I could say the action of loop diuretics is to enhance the excretion of sodium, water, and chloride. Man, I hope you're listening. I swear to God, I hope you're listening. Because I don't know how they're going to say it on your test. I have no idea. What I do know is they choose to say it a lot of different ways, which is, again, what my PhD is based on. The fact that if they switch up this language, we're going to lose half of you. So to say that I inhibit the absorption is the same thing as enhancing the excretion. You got to get that under your belt and deal with it, okay? Now, turn page, because we're moving. We are moving. If you look at the next page, it's alkalosis, but we're not dealing with alkalosis. We're talking electrolytes. So I need you to keep on going until you get to a page that looks like this. Boom, 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 boom. Okay? Now, when you get to a page that looks like that, you know that we're specifically speaking about a potassium deficit. I am spending an extraordinary amount of time on a potassium deficit because yours truly is going to have to know specifics about how to make sure you safely treat this patient with potassium. Even though most tests have a hyperkalemic patient, I am going to spend some time on the hypokalemic patient as well. Now, don't screw this up. Hypo or hyperkalemic is not calcium. It's potassium with a K. Okay, so be very careful with that alone. I've seen people screw that up. Now, if you look at the potassium deficit patient, peep this. You have a picture with a lot of guts in it. And so what I want you to know is that when you look at the potassium deficit patient, you're gonna have a lot of symptoms that have to do with the gut and of course the heart. We said the heart before, and this guy looks a little weak, right? Looks a little weird even. Okay, so now watch this. You have the alkalosis, and you already know what I'm about to say. All K is low. You got it? Now, here's what I want you to write above the potassium deficit on your page. I love the words slow and low, okay? So this is not just true for hypothyroid, it's true for potassium deficit. So if we look at the first word, it says alkalosis. Boom. Then if you look at the next one, it says shallow respirations. Uh-oh, we got two lows here. This is feeling pretty good. If we keep on going, we see irritability. Okay, that's cute. But then we see confusion and drowsiness. What I want you to think of those two things, confusion, drowsiness, is low mental acuity, right? Low mental cognition, or slow even, because they're slow to really think, right? So slow thinking, okay? Then you see weakness and fatigue, okay? You probably are slow there. Then you see the arrhythmias. The arrhythmias that I want you to focus on, it doesn't have it on here, so you're going to have to write it. A low K will give a prominent U wave. A prominent U wave. You got to write that. I swear to God, you got to write that. It's going to give you a prominent U wave. Has nothing to do with slow and low, except that I look at it like this. The letter, I should say, U, is the first letter in the word under. So if you have a high K, it's a peak T wave, like the top of a mountain is a peak and the mountain top or peak is really high K. This is a low K. So the U in the in the prominent U wave, think of a U. A U does just like this, right? That's a U. So a prominent U wave means the potassium is under where I would like it to be. It's low, okay? It's not a peak because that's way up there somewhere. So that's kind of how I remembered my EKG changes. But then also, I want you not to don't highlight tachycardia. Do me a favor, highlight the bradycardia because we want to stick with that slow and low. So bradycardia. Then, if you look at where it says decreased intestinal motility, I call that this, low mo. That's what I call it. Because ain't nothing moving, low motion, okay? Low motion in the GI system. Now, here's where I want you to do a rhyme. I like Jay-Z, you know I do. So, it's a Jay-Z rhyme. That's what I say about that. So, in the patient with a low potassium, it's going to be a gut and a butt issue. Aha! What does that mean? Well, it means nausea, maybe some vomiting, but more important than all of that is that word ileus. Where the word ileus is, you have to write this next to it, paralytic. If you look at the word, it looks just like paralyzed. Paralyzed ileus. Ileus is a small intestine. A paralyzed bowel. It ain't moving. It's not moving, okay? So basically, write down bowel obstruction, constipation, no peristalsis, and absent or hypoactive bowel sounds. Again, slow and low, okay? Because hypo means low, right? So I'm going to do those again because you care. Where the word ileus is, you're going to write paralytic, you're going to write bowel obstruction, you're going to write constipation, you're going to write no peristalsis, you're going to write no or absent bowel sounds or hypoactive bowel sounds. That's what you got to do. Now, what I explained to you is the causes. The causes are very, very easy. They're once again a gut and a butt issue, kind of, right? So here's what we got. Here's the three causes. The most common causes of a low K is puking. So puking, pooping, and peeing. If you are constantly vomiting, oh yeah, you're gonna have a low K. If you are constantly pooping or you have diarrhea, you're gonna have a low K. Those are causes. If you are having polyuria and not with the diabetic, no. Polyuria can be the patient with DI, diabetes insipidus. You might want to know that. Diabetes insipidus, not mellitus, not, sugar's too high and all that, no. Diabetes insipidus is going to have a low K, all right? So they're peeing too much, they have polyuria. Now, here's some tips. Your patient with this low K, you need to remember, if K is low, who was high? Digoxin. That's a big ass deal. Big old hairy deal. If K is low, dig is high. Here's another tip. If K is low, check magnesium. They go together, big time. I've seen that on the test somewhere. I don't know where, somewhere. Just saying. You already know you need an EKG. I don't have to tell you that. You know you need an EKG. How else are you going to know that there's a prominent U wave? You also probably know that there's other endocrine disorders. So your endocrine disorders which have a low K include DI and Cushing's. Sort of, kind of important. All right. Now, there are other reasons not as popular. Maybe the patient took too much insulin. Maybe the patient took too many diuretics. So we have a little rule, right? So if you turn the page, I want you to write some rules. Now, if you recall, you already did this page, but I want you to do some things on it again. Here we go. On this page, where it talks about potassium, I literally want you to make sure that you write on this page, what if we have hypo or low electrolytes? Here we go. Remember we talked about the high? Now I want you to come closer and talk about the low. So if you have hypo or low lights, then you got to remember we got to replace them. So electrolyte replacement. Remember how diuretics made electrolytes low? Hold the diuretics. Consider the EKG if you need to. And then remember to monitor for what? Gut and butt problems like a paralytic ileus. Write that down on this page. And then let's have some fun. If you look at this page, it says potassium chloride, IV, and PO. I want you to write what you know to write. On top, at the very top, rules. Never IV push or bolus. Write it again. Underneath the word potassium chloride, you need to write check urine output before administration or replacement. Okay? You also need to write somewhere on this page that the best way to replace potassium is actually PO, but you have to give it with food and dilute it with juice or water. I think I'll say that again. The best way to replace potassium is PO, but you have to dilute it with water or juice. Now, watch this. We have to remember when it comes to potassium that we have a patient that is very much at risk for extravasation. So we have to be very careful how we give this if we give it IV. Be very careful, check that down on IV site every hour, okay? Now, I'm gonna write all the available available ways to give potassium. So here we go. Here we go. Y'all ready? Y'all working with me? PO. You can go right to Walmart and buy PO. I'm on a keto diet. I very often will take potassium as a replacement because of the keto diet. Okay, so you can buy that over the counter. All right. Then you have something called extend release capsules. This is another PO version. Then you have liquid, KCl. Then you have something that's called effervescent tabs. These dissolve in water just like Alka-Seltzer. Plop, plop, fizz, fizz. Oh, what a relief it is. You are too damn young to know that song, but I'm singing it anyway. But these are effervescent tablets. You put them in water and they go bubbles and everything. They dissolve, okay? So you actually gotta know that. Here we go. You have the dissolvable powder packets, which you dissolve in water or juice. If you give liquid potassium, you still have to dilute it. So you know that. These are all things your cute little self has to know, okay? And anything you give, any potassium you give, you absolutely have to give it with food. You have to, okay? Now, what did I say? I said no IV pushing, no bolus, no crushing, no NG, okay? You can't crush this and put this in an NG. I said those things before, by the way. What number do you need if you're in the ICU or you're a cardiac patient? Bam, 4. Your potassium has to stay above 4 if you're in the ICU or you're in the cardiac unit. This patient needs telemetry. You need a high K diet. We said that already, so you know, this is all repeating myself. Now, you have one more paper that goes with this potassium. So turn the page and let's see if we can find our delightful spironolactone. Spironolactone, right? If you'll recall, I told you that this was a diuretic, but this was a potassium sparing diuretic. So do your girl a favor. At the top of this page, write potassium sparing. Sparing, sparing, sparing. It's potassium sparing. Do me another favor. Next to whatever you wrote that said potassium sparing, write daily weights. We've said that already. Been there, done that, t-shirt and sun visor. Daily weights. Do you have a scale before I let you go home? For this medicine, remember the A's. The A's are the brand name, Aldosterone. So watch this. Spironolactone spares the K. So there you go. Generic name spares the K. Brand name Aldosterone equals 3 A's. Here we go. Actually, yeah, 3 A's. The first A is alcoholics. What did we say? All K is low in alkalosis. Well, it's also all K is low in alcoholics. Alcoholics sound a lot like alkalosis. They are at risk for alkalosis. Their K is always low. So you need to remember that the alcoholic gets spironolactone. And this is your cirrhosis patient, as you already know, but I thought I'd remind you. If you're on aldosterone, your fruit of choice is an apple. Ooh, I lose you guys right around here. Let me explain. If I'm taking Hctz and it's potassium wasting, it's like I'm getting rid of potassium like 40 going north, then I probably need to replace it by taking in an orange for my lunch, because everyone that I put on a diuretic like Hctz or Bumex, I'm not really trying to get rid of their K. Usually I'm just trying to bring their blood pressure down. The K was just a side effect. So if I give them an orange, they can replace their potassium. Well, this drug, spironolactone, spares the K. I'm not trying to give them an orange. They already have enough potassium. I am not trying to give them an orange. I am actually trying to give them an apple because an apple has no potassium in it at all. So if it spares the K, they can have that fruit and go about their merry way versus an orange. You feeling me on this? Okay, I hope you are, because I kind of saw that somewhere. Okay, now another thing. The next name for, the next A, if you will, for the patient on Aldosterone is that it blocks Aldosterone. Now, that is actually in the bubble on your actual handout. If you read it with me, in the bubble, it talks about that. It says, save the potassium, get rid of the water, blocks the action of aldosterone in the distal nephron, gets rid of sodium and water, but saves the potassium. So here's what I want to show you. If you look at the word aldosterone, it looks just like steroid. I don't know if you know it, but you should at this point, that patients hate to take steroids. I just talked to one of my students today, don't want to take no damn steroids because she's going to get fat. Well, why does she get fat? Because steroids make you retain sodium and water. And sodium and water are very heavy and they make you gain weight. Salt and water makes you gain weight. That's just common sense. So if I take aldactone and I block aldosterone, then I no longer retain salt and water because aldosterone makes you retain salt and water. Now what happens? I get rid of it. But if I get rid of salt and water, which is exactly what aldactone does, it makes you get rid of salt and water. What's the opposite of sodium? Potassium. So if sodium goes down and salt and potassium, or sodium and potassium are divorced, then potassium's going up. They're going in opposite directions. They're not going to the graduation together. They're not going to the christening together. The sodium goes down because you excreted it, diuresis, then the K is going to go up in this patient. That is why it's called potassium sparing, because it only works on the sodium and the water. Now you've got to remember that Lasix worked on both potassium, water, salt. It got rid of all of it. Okay, calcium, everything. All right, so hopefully that helps you kind of figure this out. Now, I need you to go down to the page. You have a lot of room on this page, so that's kind of good. Oh, you know what? Shame on me. Do me a favor, quick favor. Go back to one page. Go backwards to one page. I forgot one little itty bitty thing. Sorry, guys. If you go back one page to your potassium, do me a favor right here. Can you highlight where it says no salt substitutes? And remember that salt substitutes are potassium. That's what it is. Salt substitutes are potassium. I just thought of that, sorry. Now, stay with your girl. So what? I made a mistake. Keep it moving. Go over to the spironolactone. Let's have a little fun with this. You have a lot of room on that page. You're going to use it. You're going to use it, and you're going to use it wisely. Here's what I want you to write. I want you to write that another potassium-sparing diuretic is this. Because you have more than one, and sometimes they give you other ones. Okay? So I want you to write that another potassium-sparing diuretic is actually triampturine. Okay? Now, all potassium-sparing diuretics are very weak. So I could never use spironolactone by itself. I could never use triampturine by itself if I had a very, very, very serious patient who needed a lot of water taken off their body. So what I do with spironolactone is I combine it with Lasix, but I don't need as much Lasix. Or I combine triamterene with hydrochlorothiazide. Okay, I might do that. Okay, hydrochlorothiazide, Hctz, remember that? It's a thiazide diuretic and it's potassium wasting. So since Lasix is potassium wasting, hydrochlorothiazide is potassium wasting, if I combine it with some of these potassium sparing diuretics that are weak by themselves, then I won't get rid of as much potassium as I would have had I used full strength Lasix. All right, so just write that down. This is a weaker diuretic, and another example is triamterene. I need you to know that it treats the cirrhosis patient. In particular, what I said with you on that issue, and I'm going to write it again because you care to write it on this page. You saw me write cirrhosis. What in the cirrhosis patient are we specifically trying to do when we give them cirrhosis? When we give them spironolactone, we're trying to decrease the ascites. That is our issue with that patient, okay? So you kind of know that. Another thing that I've used this medication for, and you don't care as much about this reason, my own patients, I have used it for patients who have hirsutism that's not related to a disease and acne. So I've had patients very bothered by hairy arms and the mustache and the little beard or whatever, not a beard, but you know, those hairs. And I have used Aldosterone with those patients. I'll put them on like 100 milligrams BID. But the problem is, here we go, the problem is this drug is a teratogen. So if their childbearing age, which as you know is 12 to 51, they need a backup birth control method, right? They need a backup birth control method because this drug is a teratogen, okay? Now, what kind of side effects does it have? Not many, so look in the box. Here, if I give it to that female for those hairy arms and the mustache and the whole thing, she might get an irregular period, which is another reason to use a backup method. And then if the guy takes it, the man, he might have man boobs, and that's the gynecomastia, okay? Now, here's our deal. The last part of your, well, you have two. In the little bubble at the bottom, highlight it. I'm going to read it to you because you got to highlight it. It says, remember, too little or too much potassium will cause weakness in the muscles, including the heart, because it's a muscle. And then at the bottom of that page, watch what I do. You heard me talk about Aldosterone. And it is a good time right now to give you what I would call a chain gang, because we're going to need you to understand it a little bit later. Here we go. The Aldosterone is part of the RAS system. The RAS system is this. In response to a low blood pressure or a low blood volume, which as you know could be like hemorrhaging, so you're bleeding out, right? Hemorrhaging. In response to what you get when you hemorrhage, which is shock, and then in response to something called high osmolarity, your body tries to compensate. So look at what I'm trying to tell you. The RAS system is a normal compensation or compensatory mechanism for you not to die during shock. It is in total response to shock. So when we look at RAS, and again, you wrote that at the bottom of this page. You wrote what I wrote on the board at the bottom of this page. When we look at shock and our body naturally kicks in RAS, the letters stand for renin and angiotensin those two. The angiotensin is number 1. It is converted to angiotensin number 2, and this happens in the lungs. When that happens, the action of angiotensin is vasoconstriction, and it brings up the blood pressure because you know that vasoconstriction leads to high blood pressure. So I'm going to say that again. The RAS system, there are 2 A's. Be very careful because I just described only one A even though there's 2 angiotensins. The RAS system is totally in response to shock or low blood pressure or thick blood osmolarity. What happens when you go into shock is your body tries to compensate, not let you die. Renin stimulates the production of angiotensin 1. Angiotensin 1 is converted to angiotensin 2 in the lungs. In the lungs is where that happens. That'll matter in a little while. This causes vasoconstriction, which means taking a blood vessel and going just like that. So if you take my blood vessel and you squeeze it or constrict it, it's going to take, watch this, more pressure for me to move the blood through that vessel. Higher pressures, more pressure to move blood through a constricted blood vessel. And then it goes and it makes your blood pressure go up. Isn't that what we wanted? Because look, you were here and now you are here. But we're not done. The second A, here's the first one, here's the second one, is that angiotensin, and I'm going to have to erase this just so I can fit it in there. Angiotensin 2 stimulates the adrenals to produce the second A, aldosterone. I just told you that aldosterone looks just like a steroid, and this makes your body retain sodium and water, which is blood volume, so your blood pressure goes up here as well. So again, the RAS system is renin, angiotensin, and aldosterone. This drug, spironolactone/aldactone, just blocks aldosterone. So if I block aldosterone, let's block it. If I block aldosterone, now instead of sodium and water retention, I have excretion. Because I excreted the sodium, the K is retained. That is it. That is what you got to know. Swear to God, that's how you got to know it too. Okay, so this was all about potassium. It took me forever. Now I'm moving on to sodium. I will be back. You go take your break, and Larry and I will take our break because we're going to come back and we're going to talk about sodium, which is a troublemaker, to be honest with you. Okay. Bye-bye.